Councilmember Farmer. Yes, always. Next on our agenda. I'll ask Benji Mars with Benefit Insurance Marketing to please, he's already at the podium. Presentation on the Lexington Fayette Urban County Government 2013 Health Plan Renewal. Ride 'em, cowboy.
Good afternoon, Mayor Gray, Vice Mayor Gorton, council members. First, thank you to Vice Mayor Gorton for rearranging the schedule and getting us on, knowing that we were ready to present the rates. We wanted to get them out in front of you as quickly as possible, the rates and plans for 2013, so we appreciate you accommodating us for this particular meeting. We're going to present a few slides in the beginning of our presentation that recap or go back through what was presented last week in the Financial Committee, as well as take you through the renewal for Humana and then the projected rates and plans for 2013. And then we'll be available to answer any questions you might have. First, in establishing premiums, there's a number of factors that are included in setting rates or setting premiums for plans. First, we have to include the fixed costs. Those are Humana administration, reinsurance premiums. We include the consulting fees for ourselves in those fixed costs. HSA contributions. The LFUCG contributes $500 per single employee that participates on a health savings account and $1,000 per year to any other contract on the HSA, whether that be employee spouse, employee child, or full family. Then we look at medical costs. Those include the marathon fees for the on-site wellness center. It includes their rent, utilities. We look at financing from an incurred medical claims perspective. We're only looking at claims that have been incurred in 2012, claims that are incurred under these plan designs. When we first started analyzing your finances to fine-tune these rates, we were looking at claims through June and then claims through July. And in the first couple weeks of August, we cut data off at July. So July claims that were incurred in that month had not been fully paid at that time. So we have to formulate a calculation each month to account for what has been incurred but not yet reported. There's a claims delay just in the natural progression of from the time an employee sees a physician till the time they file that claim to Humana. Humana pays it or bills LFUCG. LFUCG pays Humana and they remit the claim. And sometimes that just takes time. So we create that calculation for IBNR to true up the claims. Also included are pharmacy costs. We have the on-site RX claims. Those are claims balance for prescriptions that are filled at the on-site pharmacy. We have on-site RX administration fees, less employee copays. And then we have retail RX claims. And all those things are aggregated together to come up with a total number of which when we design plans, we determine how much of that cost needs to be attributed to each plan design. Looking back, this is a slide from last week, which just stated the problem of premium equivalents were never properly set to attribute what was actually being spent by LFUCG for employee health care. In 2012, you'll see that LFUCG is on target premium-wise, budgeting-wise, to spend $24,212,000 is roughly the premium equivalents, and you're on track to spend roughly $24,579,000, which includes all of those fees and costs and administration that we just reviewed. For 2012, when we factor in the benefit pools, the supplement, the up to $3.8 million, and then what the balance of the premium costs or employee payroll deductions, when we factor those three things, we're on track to be within your budget for this 2012 plan year. As we look ahead to 2013, a component of your cost is obviously your Humana renewal. You're paying them a fixed administration cost to adjudicate claims, to rent their network doctor discounts. you're buying reinsurance for them. And as part of our RFP process that we initially released to the marketplace, of which Humana was your incumbent, but they also participated and had to compete in an RFP process to maintain your business, we were able to negotiate several rate caps and performance guarantees for this 2013 renewal. That included a 3.5% cap on administration costs. That included a 19% specific reinsurance cap if LFUCG transitions to a $300,000 deductible from a $250,000 deductible. Your aggregate insurance, which protects the entire claims, there was a 19% cap on those rates. And then additionally, there's a $350,000 in additional performance guarantees, which won't be determined until after the plan year ends. Those are for guaranteed doctor network discounts off of billed charges. Those are also for performance and administration functions. Your actual renewal, your administration cost came in at a 3.5% increase right at the rate cap, which is a $42,000 annual increase to LFUCG. Your aggregate stop loss premium, we're actually going to recommend that you drop this coverage. Aggregate insurance, Humana sets the expected claims number, and then your aggregate insurance protects you at 120% above that number. Last year, in transitioning through all the plans and not knowing where people would end up or enroll, we felt like aggregate was a worthwhile protection. But now that we've plateaued out and we understand where people are enrolled and where your claims are, we think we would recommend that you eliminate that coverage and save the premium. Your specific stop loss premium, you've heard us talk about this up to now. Your initial increase called for an 80% increase. That was eventually reduced to 63%, or $354,000 over what you're currently paying to maintain the $250,000 specific. And I'll come back and talk a little bit more about that on the next slide. Alternatively, if we transition to a $300,000 specific, meaning you're taking an additional $50,000 of risk per individual, then your rate cap is capped at 19%, and that is equivalent to a $110,000 annual increase. We conducted a financial RFP of the reinsurance market just to ensure that Humana was in line with their renewal and what they've projected. And every reinsurance carrier that we approached declined to quote. They were not interested in providing a proposal because they were not competitive with the 80% increase or any of the other proposals as well. Year to date, and this is through the end of August, LFUCG has paid Humana $368,853 in specific reinsurance premium. LFUCG has earned in excess of $1 million of stop-loss claims rebates in excess for claims in excess of that $250,000 numbers on 5 members. Additionally, you have additional 8 members that are in excess of 50% of the stop-loss, so you have a large number of high claimants. When we factor in the $1 million of reimbursement you've received compared to the $360,000 in specific premium, as well as your aggregate premium, and as well as your administrative costs, Humana is operating through the end of August of 2012 at a net loss. After we factor in the fixed cost renewal, then we start to look at trend. And trend for this geographic region with Humana in this segment is 9 to 10% annually. Just simplifying what is trend. Trend just means that in 2013, if your claims repeat themselves, it'll cost 9 to 10% more to pay the same cost. 9 to 10% in this market, as well as nationally, that's the average that we typically see. Healthcare reform mandates, in addition to trend, are adding about 1% to your healthcare premiums for next year. This is a look at your current 5 options and your enrollment, and I believe this enrollment count was actually through the end of July. PPO A, B, C, HSA 1 and 2 are the 5 plans that you currently offer. As you can see, the total gross premium across for each of those plans. In green shading, you can see where the employee premium, the employee spouse, employee children, or family premium is and allocated for each of the 5 plan options. You can also see how many employees enrolled in each plan and in each tier, what the percentage of makeup of the employee base is for those plans, the total monthly premium for each plan, and then in aggregate, where the $24 million number comes from. This is factored and changed each month. Each month goes by, you have employees come onto the plan, you have old employees go off the plan. So this number is constantly fluctuating, but if we annualize those numbers, we're anticipating about just over $24 million in premium budgeted to cover all of the expenses we talked about in the beginning of the presentation. With all these considerations, understanding where people are enrolled, we next look at claims impact by plan. This is a breakout of the participation and the expense per plan. As you can see, PPO B, C, 1, and 2 were the 4 new plans introduced last year. PPO A was the plan that 89% of your employee base had been enrolled in previously. We left those benefits intact and trued up the cost, stated the true cost for that particular plan. And as you can see, 42% of the population chose to remain in that plan and are incurring 72% of the total plan costs. As we look at PPO B, C, HSA 1 and 2, the relative percent of claims versus enrollment, those 4 plans are working quite favorably. So that's a major consideration as we go forward and evaluating plan design and rates. This slide, this is the 2013 plans as well as premiums for those plans. As we just saw, approximately 28% of your population is enrolled in either HSA 1 or HSA 2. Those 2 plan designs will remain intact with the exception of we're removing back-end copays. Right now, on either of those 2 plan designs, once an employee meets their deductible, they continue to pay RX copays until they meet another maximum out-of-pocket for those prescriptions. Moving forward for 2013, we're removing those back-end copays. Also noted on all 4 plans, you'll note the maximum out-of-pocket. We've stated that to include the deductible. Previously, on the plan designs, you had a deductible stated and then a maximum out-of-pocket, and those 2 were not inclusive. You met your deductible and then you met another maximum out-of-pocket. Now on all 4 plan designs, the stated maximum out-of-pocket includes your deductible. So on HSA 1 plan, the deductible is $2,500 for a single employee. Once they meet that $2,500 deductible, they have 100% coverage for all medical and RX expenses. So HSA 1 and HSA 2 are actually improved plans from what they currently are. PPO 1 and PPO 2, this is a blend or a culmination of PPO A, B, and C. We took into consideration first, based on the previous slide, that once we established the correct premiums for PPOA and have gone through 3/4 of a year under that plan, we understand that that plan is actually a driver of healthcare cost, just the nature of the plan design itself. So we chose to blend the 3 plans, also hearing employees in that PPOC, the maximum risk or the maximum out-of-pocket was too high. So we reduced that from $5,000, that totaling the deductible and the max, down to 4. So we've taken those considerations and spread those off into 2 different plan designs, and then these are the rates for those 4 plan options. I'm going to come back to this slide very shortly. My understanding that for 2013 is that your benefit pools by division will remain the same as they are today, as well as the LFUCG supplement has been approved through the first 6 months of this plan year, which is the end of your fiscal year. So for at least these first 6 months, the supplement will remain intact as well. Newly introduced for 2013, we will be giving a premium credit for non-tobacco users on any of the 4 plan designs for single And for employee plus children, they will receive a $25 monthly premium credit. For anybody that's an employee spouse or a full family and non-tobacco, they'll receive a $50 monthly premium credit. As we back up and consider these slides, again, 28% of the population is enrolled in HSA 1 or 2. For non-tobacco users, based on the premium and based on the credit, that means those people will have an enhanced plan, as well as those enrolled on HSA 2, employee spouse, and employee child will actually have a payroll reduction over what they're paying today. Those currently enrolled in HSA 1, non-tobacco users, will experience just a slight increase, and by slight increase, about $1.40 per paycheck. But they're taking a $1,500 less risk by eliminating that $1,500 of back-end copays. The majority of the population on the PPO plans was enrolled in PPOA. 100% of non-tobacco users from PPOA will receive a payroll reduction regardless of which plan they use. We know that everyone enrolled in PPOA, whether tobacco or non-tobacco, is 100% financially better off by electing HSA 1 if they are eligible to participate in that. Simply taking the $182.29 differential in the cost of the plan from what they're paying today for single coverage and transitioning to HSA 1, that's $2,687 in annual premium savings. If that money is taken and deposited into an HSA, $2,187 savings plus $500 HSA contribution from LFUCG, that's $2,687 they can have in their HSA account over the course of 12 months before they've had to come out of pocket any additional money to pay for expenses incurred under the plan. $2,687 is $187 more than the maximum out of pocket for that plan design. So in a worst case scenario, if they took what they're paying today and contributed that to the health savings account, if they hit their maximum out of pocket, they'll still have $187 left at the end of the year before they've had to come out of pocket any more money. Now we know that that plan design is not for everybody. So we're not suggesting that that's the best plan for everybody. We're just simply stating that financially that's a better position. Different people like different plan designs. And so therefore, because of the high number of enrollees in PPOA, we wanted to design a plan that was as close to PPOA that blended the three plans together, and that would be PPO 1. PPO 1, in comparison to those currently enrolled in PPOA, maintains the free cost to use the LFUCG Health Center, no copay. The prescription cost at retail and at the on-site pharmacy remain exactly the same, so no change. And between those two elements, that's roughly 35% of the total plan cost without change. In combination with physician copays. The $15 primary care physician copay is exactly the same as it is today, and the specialist copay is going up $5 from $25 to $30, again, relative to those enrolled in PPOA. The biggest difference between the two is if you look currently, PPOA has a $500 inpatient copay. You currently pay that copay as often as you're admitted to the hospital with no end in sight. There is no maximum out of pocket. Under PPO 1, you have a $500 deductible, which is a one-time annual expense. And then once you've met that deductible, you pay coinsurance until you've reached a $1,500 maximum out of pocket. Once you reach your $1,500 maximum out of pocket, the only thing you have left to continue paying are copays. You have 100% coverage for all things emergency room, inpatient, and outpatient services at that point. That's the equivalent of someone having 3 inpatient copays under this current plan year. In addition to that, PPOA non-tobacco user will pay a reduction in cost to transition to that plan if they choose to do so. Our expectation is that approximately 50% or more of your population will actually experience a payroll reduction based on the plan they use. With 28% of the population enrolled in HSA 1 or 2, that's another high percentage of employees that will experience either the same or a reduced payroll reduction for a better plan. And with that, I'll open up for questions. And
Councilmember Stinnett.
Thank you, Mayor.
Benji.
Thank you for the presentation. And this is a lot to grasp in a 15-minute presentation. I know there's going to be a lot of questions from council and the employees of our government over the next several weeks. So we appreciate your patience in answering those. Just a couple follow-up questions. You quoted some numbers and stuff from last year and what we've used to date this year. Is our usage up or down from last year?
your usage, claims usage?
Yes.
Oh, it's down.
And do we know what percentage is down?
I don't offhand. There's a obviously going from the 37 million down to 24 and a half, 25 million, but there's also a change in enrollment and change in population, so I don't know exactly balancing those two out. What the
you said that our costs actually went up about 9%. Your cost,
the 9% is looking ahead at 2013 and applying trend. We actually backed off that. If HSA 2 is about a 5.7% increase.
Okay.
HSA 1 is about a 6.5% increase. But then when you consider the premium credits for non-tobacco, that brings that down to almost nothing.
Yeah, but I'm just saying we had a cost increase.
Absolutely.
I think a lot of people need to understand that we didn't just have an overall savings. We had that, but we also have increased costs for pharmacy, for the medical piece, for marathon, and for administration costs too. I know the national average projected for next year is 4% across the country, that people in the United States will pay additional 4%, and last year it was 9%. So, and that's because what you just said, and I asked you about usage, is people are using their plans less because of the deductibles changing and things like that. So this is no different, I'm trying to point out, than the public sector or private sector. We're all experiencing the same cost and increases in deductibles. I know you all see it in the private sector. So this is playing out the same for the public sector as well. In terms of the plan prices, there was no way. Did you look at keeping Plan 1 the same as PPOB in terms of cost last year? Because it's similar to that plan. Obviously, it's a better plan actually than PPOB.
It is a better plan than PPOB, and the challenge there is because we've got to, if you look at the utilization on PPOA, we've got to make assumptions about where those folks will enroll and migrate to. They're bringing a large claims per employee per month number with them to the plan that they go to, and that's part of the impact of cost. PPOB, for somebody enrolled in PPOB, if they choose to go to PPO2, right now that person in PPOB has a $500 deductible, a $2,000 max for a combined $2,500. If they choose to go to the new PPO2, they'll take an additional $1,500 of risk, but they save almost $1,200 in payroll deductions. So, and then to go to PPO1, they get an enhanced plan by saving $1,000 in total maximum risk plus reduced copays, but they have to pay additional for that. Because PPOB was one of the smallest participating plans, it was just a balance of.
And obviously, council members, we can all see how complex this is. I mean, there's a lot of moving parts when you start talking about this. And one big number that we all need to understand: 72% of that 24 million came from the PPOA plan last year. So if that plan's gone, that 72% has to filter into the other 4 plans. And it's just as a projection. We don't know where everyone's going to jump to. Each person's situation will be different, but we have to make up 72% of our claims in these other 4 plans, and that'll be closer to getting us on a real track so that next year it'll be even easier to keep the costs low and project it out going forward. But this is a big transition year again, and I appreciate your hard work. I will emphasize one thing: we need to educate people. We need to educate people. We need to educate people. And I know you're ready after what we learned last year, ready to go out and do this, but please let's get the word out and let's make sure people understand this.
Absolutely, and I think your HR team has a great game plan for doing just that, almost daily from here to the end of October.
Yeah, that sounds good. Thank you. Thank you, Mayor.
Thank you, Councilmember Stinnett. We might want to just give us a preview, give us a picture of what that plan, that information plan represents.
Here in the next day, today, tomorrow, employees will be released a survey, Q&A survey, so that on a daily basis, at any point, employees can go into the link that will be sent out, and they can view the ongoing questions and answers that have been asked, as well as they can ask any related question to the health plan. And we're going to make every attempt to get those answered within 2 business days. So as employees type in questions that they have for the plan, we can respond back and continue to build the Q&A as we go. So that's going to be launched within the next day or two. Within the next 2 weeks, I believe we'll be doing what's called a go-to-meeting presentation, where we'll invite members of divisions to participate from typically noon to 1 on any given day, where we'll go through a PowerPoint presentation via a webinar, where people can call in telephonically. They can also watch from their computers. They'll be able to participate that from typically 12 to 1 each day of the week, Monday through Friday. We're going to film a video presentation that will run continuously on GTV. That will be a presentation like an employee format, where we do a Q&A as well as a benefit explanation. And we'll also be releasing a book that Mary Lyle's been working hard on that gives more detail, plan detail, designs. That'll come out within the next few weeks. And all of these things will be done prior to the actual open enrollment, as well as we'll have some site locations where we go out and do meetings leading up to PeopleSoft opening up for open enrollment choices.
All right, thank you, Benji. Councilmember, Vice Mayor Gordon.
Thank you, Mayor. Thank you, Benji. That was one of the things I was going to ask you about, was the education program. I remember last year that there were lots of employee questions coming to lots of different people, and I really like your Q&A survey that employees will be able to ask questions, and I guess everybody can see all the answers.
Correct.
All the questions and all the answers.
That's great. They won't be able to see all the questions that are asked.
Right.
There are some, based on the surveys in the past, we typically have 1 or 2 that are not relevant to the topic, but we'll try and keep them relevant to healthcare and respond back, and we'll continually update the list. We won't take anything off. We'll just continually add to it as we go, and try and get everybody's questions answered in a timely fashion.
And then the webinars, employees can watch from their office or from
That's correct.
their computer. That all sounds really good. Would you tell me again which date you said open enrollment begins?
It'll begin the end of October. Either the 15th or the 22nd.
Okay. Okay.
We've got some timing with PeopleSoft loading programs, plans, as well as Humana getting plans and designs to them as well.
Okay. And then I want you to talk a little bit about the tobacco, non-tobacco use, how that will work, how, what employees will need to do to verify that they are non-tobacco users, et cetera.
Sure. As a part of the enrollment process, open enrollment, everybody, when they go through PeopleSoft and elects plans, one of the first things they'll be asked is simply, are you or your covered spouse a tobacco user, if they're covered under the health plan. They'll have to attest that either yes or no. And then for those that attest that they are not tobacco users, going forward there will be random nicotine tests, as in any typical plan, just at random, completely at random, and that's quite simply how it'll work.
What if an employee refuses the test?
If they refuse the test, that would be a policy question.
How would that? I mean, I think that all needs to be worked out ahead of time.
Yeah, no, it's definitely.
Vice Mayor, we are working on a policy for that, but any employee would have a right to refuse the test. They would be charged, the tobacco rates.
I see. And if the employee through open enrollment, you said they have to say, yes, I'm a user, or no, I'm not. Is that a legal statement, or what's the status of that statement?
Well, there are some legal implications in making an election, and we do have to provide some opportunity to get enrolled in a cessation program. If an employee is a user, there'll also be some parameters on how long they would have to be a non-user prior to signing the affidavit. So there are some particulars that we're still working out, but we'll have worked out shortly.
And are you, if the employee does not choose to answer that question, will you have a policy for that, or what if an employee says, I'm not going to answer that?
Sure, they'll just be charged the normal premium without the credit.
Okay, so one would have to verify that they're a non-user.
Correct.
Whether they answer that question or not.
That's correct.
So they'll just be charged the regular premium if they haven't answered it.
That's correct.
Okay. Well, just in the last few seconds I personally, and as a registered nurse, applaud this policy. Companies have been doing this for many, many, many years. And we are behind the curve on this, but I'm glad that we are catching up. Because, of course, all the science with smoking has shown that when our employees don't smoke, they generally have some good health benefits or use tobacco. So thank you for attending to that this year.
Very good. Thank you.
Councilmember Myers.
Thank you, Mayor. Thank you for your presentation. And I wanted to start with the education program. For those who have satellite TV, who don't have cable, they won't be able to see that on GTV3. If I'm maybe a field employee like code enforcement or something like that, I'm out in the field at 1 o'clock and I can't do that, and there's some employees who don't have computers. So do we have a plan for addressing that part of our population?
Yes, we had actually talked about burning that onto discs, so people could watch that at their leisure. They could watch it at home, or if somebody requests that with them, we'd be able to provide that.
Okay. If they don't have a computer, how quickly will you be able to get those messages that you send out daily to the people who don't have a computer?
The updated Q&A?
Yes.
We'll probably take the approach of having divisional leaders print those out, because it'll just be a standard Q&A, 2 or 3 times a week as it's updated, and post that for people to see.
Excellent. And then could you include in your Q&A questions from employees about how they are able to have access to the information you're putting out there?
Oh, yes,
so that if
absolutely.
they come up with an idea that if you do it this way, it'll help us to get it. The smoking cessation program, are we going to automatically offer a couple? I think I said in the past on this topic, I worked for a company 20 years ago that went to a smoker's rate and a non-smoker's rate, and they offered all the employees and anyone in their household 2 opportunities for a smoking cessation program that they paid for. I know it's a private sector. I don't know if we can do that or not, but is there a plan for those who have maybe always wanted to stop smoking to provide the smoking cessation up front?
There is a plan to provide, and as a matter of fact, we're evaluating costs, employer costs versus looking at voluntary plans. We're looking at Marathon will be able to provide a program for employees to use at no cost. We're looking at other local agencies that might participate in that as well. We're evaluating the cost of, for instance, potentially waiving the copay on Chantix. And I think currently the policy is 3 trials of Chantix at no. So those things will be a part of this program as well.
Okay, and Chantix, is that a smoking cessation
It's a smoking cessation drug. It's one of the more prevalent, prominent, accepted.
Okay, and then last question is the CHIP program.
Yes.
You have a date when you might bring something back to us?
As we talked about last Tuesday, we'd submitted that information. Your legal team has reviewed it. They've marked it. We had questions internally. John and I met and discussed those. That proposal, that contract reworked, is back in CHIP's hand right now, and we hope to have an answer for them in the next few days. And then that's what's my understanding is that is required before it's blue sheeted along with the contract.
Okay, then after that, that's okay. Okay, thank you.
You're welcome.
Thank you, Councilmember Myers. Councilmember McCord.
Thank you, Mayor. So, Benji, just so folks know what's happening here, you're presenting this. This is the first time we've had a chance to really see these rates. You're not asking for council's approval. You're basically just informing us this is what the rates are.
That's correct.
Okay. So, when will this go on to the docket, or is this going to be walked on Thursday night? Are we moving it forward?
My understanding is that this isn't required of council approval.
Okay.
That this council approved the budget of the benefit pools, and that's the approval that goes into that process. We did have council input. Council member Stinnett gave us some great input, as well as Vice Mayor Gordon and Council Member Kay and Henson and Beard. So they've been a part of that process at the end, and so that's my understanding.
Well, and again, last year things changed so radically. A lot of folks, a lot of employees didn't quite understand the process, and so again, this is a function of the administration. We set the budget. Here's what we're going to spend. The administration engages you all to help craft that, come up with the best offer that we can, and council is made aware of it. It's not a council decision. Council's not setting these rates. We're just being made aware.
That's exactly correct.
Thank you. I just want to make that clear for folks watching. Thank you.
Thank you, Councilmember McCord. Councilmember Stinnett.
Thank you, Mayor. Benji, I want to, and this may not be for you, so I apologize if you, but Mr. Driscoll, he said that the subsidy is only in there for the next 6 months. But the council, we were under the impression when we set the FY 2013 budget beginning July 1, we were doing the subsidy for another 12 months.
It's just the way the budget year falls.
No, I just want to make sure it's in there for the first 6 months of next year.
Yes, for the first 6 months of the calendar year.
But the way it sounded, it's like it was only in there for this 6 months, and then next year, January 1,
Follows through the budget that you've approved.
I just want to make sure, okay, that we got that straight. I didn't want anyone thinking it was just for half the year, because that does get confusing with the. And Benji, do we look at trying to get the health plans? Have we looked at that yet? In sync with our budget year? Have we looked at advantages and disadvantages of trying to do that?
We discussed that a lot last year.
Right,
and,
I remember
and
that.
we haven't revisited it since then, of trying to sync those two. I can see where it could be advantageous and you know, a disadvantage as well, but you know, it just comes to your all's directive of having, if you chose to move it to that cycle of having a short plan year and then readjusting again at the end of 6 months. And again, at this point, you know, we're evaluating and basing these plans off of 7 months of claims, really. So you run into the same position in terms of projecting, and so. But to answer your question, no, we've not revisited that.
Or we could take a long plan year and go 18 months to get us back on sync. So there's two ways to skin the cat. I just, you know, maybe once we get some a little more closer to normal type plans every year and get some consistency after this year, that's something I hope we can look at, Commissioner Driscoll, is to see if, because that would help us on budgeting a lot and claims, and I think it'd help ease some of the confusion. And I want to point out, last but not least, these plans are better benefits than last year. I think that's been missed here. These are better benefits, and for the most part, for most people on, will pay less this year with the non-smoker subsidy. So, you know, trying to keep healthcare costs, once again, when they're going up 9%, is a very difficult job. It's a national debate, even in the presidential election, as we all know. So thank you for your hard work. I know it's not going to please everybody. It's still hard on our families out there, but you know, we're all facing this, and you know, we just got to learn to manage our health care costs. Thank you. Thank you, Mayor.
Thank you, Councilmember Stinnett. All right. If no one else signed up to speak, so Benji, thank you.
Thank you.
Thanks very much, Mr. Marr. All right, we can move on then.